This is my first presentation among a series aiming at shedding light on the microscopic features in a biopsy that have to be known by both dermatologists and pathologists interested in the study of dermatopathology. The stratum corneum. The stratum corneum is the uppermost layer of the epidermis. And this is the whole epidermis, and a diagrammatic presentation of the stratum corneum reveals that it is composed of 15 to 20 layers of terminally differentiated keratinocytes. That is the stratum corneum, which is formed of non-nucleated or anucleated squamous cells. Squamous cells are flat cells, as you can see here, and they are held together by lipids. And they have got an important function as a first line of defense to the whole body, the first line of protection. They represent a barrier to the epidermis. This is how things go. Now, the normal stratum corneum. What about the normal stratum corneum? How does it look like? We call this orthokeratosis. You can see in this slide the stratum corneum to have the appearance of a basket weave pattern. As you can see here, the basket weave threads of keratin in a basket weave pattern. And why does the stratum corneum have this basket weave appearance in formalin fixed specimens? It's because substances within the horny layer are not fixed by formalin and thereby become washed away during processing of the slide. That is why you can't see except all these keratin fibers without any horny, without any substances being revealed. So keep in mind how a normal orthokeratotic stratum corneum looks like. Now, a deviation from normal, is it deviated from normal? How does the stratum corneum look like in this case? What is its appearance? Or, in other words, how can you describe this stratum corneum and that stratum corneum? Can you see any basket weave appearance, any basket weave pattern? Well, I can evidently not see this basket weave pattern neither here nor there. What I can see here is a stratum corneum that shows keratin, which is thick and compact and arranged in parallel lines parallel to the underlying epidermis. This case we refer to, in this case, if I see this stratum corneum, what do I call it? I call it compact hyperkeratosis. Sometimes even we say it is a compact hyperorthokeratosis or orthokeratinization in a compact thick pattern. Now, a question to be asked. What do you see here? And again, I mean the stratum corneum. Is it a disease process or a natural variation? What do you think? Before we think about it, before we try to figure it out, remember that there are always natural variations in the microscopic picture of the skin, depending on the site of the biopsy. So, before judging on a slide like this as being pathologic, ask yourself about the site of the biopsy. Take a look at the request form and search for the site of this biopsy if you didn't take the biopsy yourself. Because, for example, acral skin can give you this picture of a markedly hyperkeratotic compact stratum corneum. And this is the case or the situation in this image. It comes from a patient from the acral skin of a certain disease process. It is not a disease process related to the keratinization because this patient was suffering from vitiligo. Now, what is the value of a keratotic plug? You can see here the keratotic plug in the circle. First of all, one has to know that serial sectioning of a slide can demonstrate how this plug is frequently connected to the follicular infundibulum. Thereby, one is expected to see these plugs, for example, in clinically follicular lesions, like in the case of PRP, sometimes even in the case of lupus erythematosus, it's evident. So think about the clinical pathological correlation if you see evident keratotic plugging in a biopsy, and take a look at the clinical presentation, whether it's related to follicular lesions or not. So you figure out everything in a biopsy. You read the biopsy as if you're a clinician, if you're a pathologist, and you read it as a clinician to figure out how the clinical picture is demonstrated in a biopsy. This is a follicular keratotic plug. Now, what is your finding within the stratum corneum? Well, in this image, something looks different within the stratum corneum. Can you see all these spindly, bluish nuclei that are retained within the stratum corneum? What do you say about it? Now, this is quite different from the case of hyperkeratosis, which is composed usually of keratin, dead keratinocytes, no nuclei. Here, nuclei are retained, and in this situation, we call the stratum corneum parakeratosis, parakeratotic stratum corneum. Knowing that nuclei are preserved means that the epidermal turnover is high, giving no chance for enzymes within the granular layer to degrade the nuclei. This happens in psoriasiform dermatoses, and in which psoriasis, of course, is the prototype. Psoriasiform dermatoses are a group of lesions that we will be covering in future sessions. Now take a look at this one as well. Here, it's quite evident how nuclei are retained. You can see them here and there, everywhere. These spindly, bluish nuclei are present in the stratum corneum, parakeratosis again. Now, how should you describe the stratum corneum in this image? You can see here the parakeratosis. Here, there, this is parakeratosis. This is retention of nuclei within the stratum corneum. What else do you see? You find here lots of polymorphonuclear leukocytes, neutrophils, are present between the stratum granulosum, and the stratum corneum. This means that they are below the stratum corneum or subcorneal, and this is considered a subcorneal abscess, to which a long differential diagnosis exists. Among the differential diagnoses, psoriasis is one type or one cause of this subcorneal abscess. Sometimes preservation of nuclei takes different patterns. What is the difference in this horny layer? What do you see here? Here you will see alternating ortho and parakeratosis, alternating ortho or normal, no nuclei, and parakeratotic areas here. Let me show it to you here. This is here in this area there are no nuclei, whereas in this one there are nuclei that are arranged either in vertical or horizontal tiers. Take a look. Here, nuclei above each other. Here, nuclei above each other. And in this area, there are no nuclei. Take a look here. These alternating ortho and parakeratosis in both vertical and horizontal directions gives the stratum corneum a checkerboard appearance. Hyper and parakeratoses are especially perifollicular. You can see here in a perifollicular, this is the follicular plug, and in a perifollicular place, situated in a perifollicular site, okay? And in this case, this is consistent with what we call PRP, pityriasis rubra pilaris. It's related to hair follicles and taking a follicular appearance. So if you can see this checkerboard appearance in a lesion together with the psoriasiform hyperplasia that we're going to talk about later, as well as this checkerboard appearance that is related to follicular plugs, you might as well say that the diagnosis is PRP. Here, alternating areas of hyperkeratosis and parakeratosis occupy the whole stratum corneum. But in this case, it's not a checkerboard appearance. There are areas of hyper and areas of parakeratosis along the whole stratum corneum. This alternating pattern of hyper and parakeratosis can be indicative of a regenerative process, like in a case of subacute dermatitis, where regeneration starts to happen, leading to areas of increased epidermal turnover, and thereby areas of hyperkeratosis will become alternating with these areas of turnover that will lead to the parakeratotic zones. Now, what are the other data you can deduct from the stratum corneum? Can you tell whether this biopsy is taken from an early lesion or a resolving lesion? How can you say this? What is the difference between this biopsy and this one? Can you see here how the lowermost area or layers of the stratum corneum show parakeratosis, whereas the uppermost areas are orthokeratotic? Basket weave appearance? In contrast to this one, where the basket weave appearance occupies the lowermost layer, while the parakeratotic zone is pushed by this orthokeratotic layer upwards. What does it mean? It means that this is an early lesion where still some of the orthokeratotic stratum corneum still exists, but is being pushed away by the pathology, the parakeratosis. Whereas this is a resolving lesion where the orthokeratosis starts to develop and it pushes out the parakeratotic lesional stratum corneum in front of it. So this is the difference between this and that. So, as you